Next in our series of lectures on the principle of justice, we'll look at right to health care. In this brief presentation, it's not like we're going to actually be able to cover this in depth, so I just want to be clear about what we're actually going to accomplish here. We're going to look at arguments supporting rights to health care, and then the right to a decent minimum of health care. And then I just wanted to introduce this distinction between a globalist versus a statist perspective too. Let's begin by looking at the arguments that support rights to health care as Beecham and Childress present them. So the first argument is this appeal to collective social protection. The idea is that threats to health are relevantly similar to threats presented by crime, fire, and pollution. We have publicly funded institutions, organizations, and agencies that handle those threats, police departments, fire departments, EPA, things like that. And so this argument is appealing to a sense of coherence. So if the government has an obligation to provide one type of essential service, then it must be, or it must have an obligation to provide another relevantly similar essential service. The problem with this is, as Beecham and Childress point out, that there are some relevant dissimilarities between health and these other publicly funded agencies that try to reduce threats. One of them being that the good of health care is ultimately for individuals, whereas police departments, fire departments, EPA, that's for the broader public. And so they ultimately say that the argument from collective social protection might seem to fail, or at least be incomplete. And arguments from libertarians would ultimately arguments from libertarians would pick on this issue about it being sort of a tax imposed on all individuals for the sake of others without there being any free choice here. And as the authors also say, that non-libertarian theories of justice, this argument from other comparable government services generates a public obligation to provide some level of goods and services to protect health. But then we get into those relevant dissimilarities. So another way in which this argument might make an appeal to a certain principle is reciprocity. So society should give a proportional return on benefits received from the individuals, with all alike sharing the burdens of taxation necessary to produce these benefits. And so this might look like something about like discovering treatments that would benefit all involved. But as Beecham and Childress say later here, it's even if the government funds drug research and regulates the drug industry, this activity does not justify the expectation that the government will subsidize or reimburse individuals' drug purchases. Accordingly, this first argument in support of a moral right to health care secures only a right to a decent return on society's investment, not a full return, meaning that this sense of reciprocity isn't such that everybody else is supposed to take care of an individual's interests in full, that there is some reciprocal dynamic going on here. The second argument is this argument from fair opportunity. And so this is the idea that there's the need for health care is greater among the seriously diseased and injured because the cost of health care for them can be uncontrollable and overwhelming, particularly as their health status worsens. And insofar as injuries, diseases, disabilities create profound disadvantages or reduce an agent's capacity to function properly, it seems as though justice requires that we use social or societal health care resources to counter these efforts and to give persons a fair chance to use their capacities. Obviously, since we were talking about the fair opportunity principle, Beecham and Childress are suggesting that this would be the more appropriate route to pursue this question about supporting rights to health care. If we accept that health care is a right, then we also have to clarify to what extent should certain health care needs be met. So one approach proposes a right of equal health or equal access to health resources, and this would be a more meaningful right of access to health care, which includes the right to obtain specified goods and services to which every entitled person has an equal claim. Now, Beecham and Childress argue that this might be too idealistic. Instead, it seems like the right to a decent minimum of health care presents a more attractive goal. And so, how do we see this playing out? It's a more moderate, egalitarian goal. It would be like a two-tiered system, and it's sort of like what we have in place right now. So, instead of everybody getting equal access to all healthcare resources, instead you would have a decent minimum, which would be this enforced social coverage for basic and catastrophic health needs. And then you would have another tier, which would be voluntary private coverage for other health needs and desires. So if you see here on the screen, this is for Medicare supplemental plans. So obviously Medicare is a governmentally funded health insurance, but it doesn't cover everything. So you can also volunteer or choose to take on these supplemental plans to cover more of your healthcare expenses. But the whole idea here is that Medicare will ultimately cover these, or at least access to treatments that would be considered necessary to uphold this decent minimum of health. And so the decent minimum offers a possible compromise among various theories of justice because it incorporates some moral premises that most theories stress, including egalitarian, utilitarian, capabilities theory, well-being theory, and libertarian approaches. So if substantive standards are contested regarding what counts as a decent or sufficient level of healthcare, then there would need to be fair procedures for reaching an agreement between the people who have this disagreement. So ultimately defining what counts as a decent minimum of healthcare would be a challenge, but as Beecham and Childress suggests, this would be the more moderate egalitarian goal that would probably be realistic. And as you see on the screen, it's the one that seems to be more active here. The big problem is if you start mandating or having this government-funded insurance, you might be concerned about risk takers or people who ultimately want to decide not to have this coverage. And so Beecham and Childress talk about whether society can fairly exclude risk takers from coverage. And they say that society would first have to identify and differentiate the various causal factors in morbidity, such as natural causes, the social environment, and personal actions. And then second, the personal actions in question must have been autonomous. So if people ultimately undertake risk-taking behavior that isn't autonomous, then how can they be held responsible for those hazards? If risks are unknown at the time of an action, individuals cannot be justly held responsible for their choices. So imagine 70 years ago when people were smoking and they didn't know that there were adverse health consequences from it, right? Do those people count as risk takers and they shouldn't have fair access to coverage to cover the healthcare expenses that are related to them? And going back to this first point, it would be difficult to identify what the causal factors in morbidity are. So how do we begin to say that if you have one alcoholic beverage every day, then you are a risk taker that doesn't deserve access to coverage, when in reality, maybe that's not actually having the effect that will ultimately lead to a person's death or serious illness. So that's one side of this, that although we might have a visceral reaction that risk takers are just disproportionately taking advantage of the system, it's not necessarily clear how we start to define risk takers and how much responsibility they have if their decisions are not autonomous. And so, as Beecham and Childress say, it is virtually impossible to isolate causal factors in many cases of ill health because of complex causal links and limited knowledge. And despite these problems, it does seem fair in some circumstances to require individuals to pay for higher premiums or taxes if they accept well-documented risks that may result in costly medical attention. They provide this example of alcohol-related liver failure insofar as people who drink a lot, they know that it has a negative effect on their liver. Is there a case to be made that they are lower on the recipient list because they take these risks? Beecham and Childress say that it's I don't want to call it a slippery slope, but it is problematic. Let's just go with that, because arguments for their lower priority or total exclusion often appeal to the probability that they will resume a pattern of alcohol abuse and again experience this liver disease, thereby wasting the transplanted liver. But then they go on to talk about how when previously or alcohol-related liver disease, those types of patients, as long as they abstain from alcohol, they ultimately do just as well as other patients who have to receive a liver. So Beecham and Childress's final conclusion here, or at least on this topic, is that patients should be evaluated on a case-by-case basis, considering medical need and probability of successful transplantation, rather than being excluded altogether. Or alternatively, they shouldn't be considered a lower priority automatically. And so I think that that's a reasonable take to have. This whole idea of identifying risk takers because we feel like there's a disproportional drain on medical resources, I think is misplaced if we start to try to generalize to like different groups or try to lump people in based on certain behaviors that they exhibit, because it ultimately comes into conflict with the underlying goal, which is to meet the needs of the patient. And as a healthcare professional, and as Beecham and Childress keep on arguing throughout this book, the main job description here is to seek the treatment that's going to produce the best result for your patient and look out for their best interest. But of course, issues of justice are social issues that raise a number of complications, so totally appreciate that. But I think what's going on here in these two sections of the reading, they are trying to show that it's more complicated than mandating a certain decent minimum and saying that if anybody is engaged in risky behavior, then they shouldn't have access to it. So like I said, you might go through it a little bit more detail, but that's sort of the flyby here. To end, I just want to look at this distinction between a globalist versus a statist approach. So we were just talking about a right to a decent minimum of health care, and then the question becomes, who does that extend to? Do you think that it extends to just the people within the particular state or nation that you live in? Are they only limited by the political boundaries? Or does this right to a decent minimum apply to everybody universally? Well, the first type is a statist position. It argues that the rules that are ultimately made only pertain to or only extend to the limits of a political boundary. Globalist approach thinks that there is a responsibility to ensure that everybody has access to a decent minimum of health care. I do want to say before we get to the particular philosophers here, if you're a globalist, it doesn't mean that you are not you're not invested in the healthcare outcomes of people within your political boundaries. Instead, it's just a more demanding position to say that we have a responsibility beyond our own political boundaries. So just to be clear, that's what we mean by these two different positions here. So we have two statists and two globalists that appear in the text. So the first one for the statist was Hume, who argues that all rules of justice are inherently local, even though the reasons why rules of justice are needed in states are universal. So even though the rules might apply in every political unit, the actual rules that are created only apply within the confines of the political boundaries. And then Rawls offers something pretty similar. So there are universal principles of justice, even though specific rules of justice, such as those found in national health policies, are not universal. Same thing going on here. Universal principles, but not universal rules. And then for globalists, we talked about Peter Singer before. He had a pretty demanding argument about our responsibilities. He's utilitarian. Responsibilities related to beneficence, just FYI, or to remind you. And so he argues that morality requires more of us beyond the actions and obligations of individuals, communities, and nation states than many had thought, especially in advancing or in addressing global poverty and ill health. And then we get Thomas Pogge, who argues that a consistent moral theory that embraces universal principles will apply those principles everywhere. Now, I'm not trying to make an argument for one position or another. I don't think Beecham and Childress are necessarily trying to give us a particular end or conclusion to this, but I think it's important to know the distinction because it's helpful to know that when you are making a certain argument, whether or not you are, it's important to know the scope of your argument and how far it applies. And so this is more of a if you're interested in public health or more political ambitions when it comes to supporting healthcare in the future, I think this is an important distinction to know. Recap, we first looked at two different arguments supporting a right to healthcare. The first one was an argument from collective social protection, saying that threats to health are relevantly similar to threats presented by other parts of our social fabric, like crime, fire, and pollution. And so this was an appeal to coherence, that if those things are protected by the government, then maybe health should be as well. We saw that there were a couple problems with that, since health is ultimately an individual good rather than a social good. Then we had the second argument, an argument from fair opportunity, and this was the idea that there's a need for healthcare, especially to address those who are more seriously diseased and injured, because the costs of healthcare for them can be uncontrollable and overwhelming, especially as their health worsens. It seemed as though Beecham and Childress were going for that argument. If there was going to be support of one of these, it seems like that's the stronger one. Then we talked about the right to a decent minimum of healthcare, which requires everyone to have equal coverage for treatments that are deemed necessary based on a quality of life standard that we ultimately decide. So as we were talking about with that issue as well, how do we decide the appropriate level or the appropriate quality of life standard to sort of enact or uphold? And so that can be difficult, but that doesn't mean that we have to shy away from it. Just because it's something that's difficult or complex doesn't mean that we don't have a responsibility to ultimately uphold this notion or follow through on this rule. And then we just finished by looking at distinction between a statist versus a globalist. So statist believes that issues concerning healthcare rights should be limited based on political boundaries of nation states, whereas globalists are thinking about these healthcare rights as a matter of international concern.